My question's pretty simple. I just want to focus on clinical data, so whether that's coming from RDTs, whether that's coming from ELISA assays, point of care, the big analyzers, and I'm talking in field. Those data streams that are coming out, I guess the question is threefold. How open are those in terms of sharing that data across regions to inform evidence for policy? How open is that? I guess the second question is, do we need an honest data broker in terms of all the various data streams coming out? Who needs to be managing that? And then the third question, I guess, is, should that be private sector? Should it be a public body? Should it be a supernatural agency? Who should that be with? So I'd like to ask that to Blaine first, because he's closest.
I think, to be honest, looking at it initially, some of the countries we've been talking to, for example, Honduras, which would be smaller than Brazil, they look towards managing it themselves and being very much sharing it throughout the country. But then you can see countries like Brazil who like to keep their states very, very separate from each other. So there's going to be aspects of that. In terms of actually a broker, I think we haven't looked into that, but definitely it's a very good idea, simply for the fact that this data obviously is very valuable and can be used for many, many reasons, and it can also be exploited. So definitely someone should be a broker in between.
Okay. Should it come from private or public, or I suppose that's kind of your answer?
I think in Latin America, as it stands right now, the private sector is very, very bad for sharing anything with each other and with the public sector, so definitely not. Okay. I think it would be more of a public play.
Okay. The same question to Andrew, simply because you're...
Second in line.
Yeah, second in line.
Okay.
Firing line.
Yeah, well, I kind of agree with Blaine, really. I mean, we're Greenmash is a technology company, so we don't take ownership of the data. We're just enabling the capture and use of the data. So in terms of what happens with the data, that's really down to our clients to work out between them what they're going to do with it. I think there's certainly a push now within the whole community to make data open and reusable. Certainly within countries, I think ministries are starting, certainly in the countries we work with, they're starting to understand the benefits of sharing. They want to see what works and what doesn't work in other countries, and in order to get, you really need to give. So I think that's becoming a more, all the talk in the sort of mobile health tech space in developing countries is all about open data sharing. There's various formats being put forward as to if your data is available in this format, it can be used by anybody. So in terms of how the private sector fits in, again, I think I agree with Blaine that it's more likely to come through academia, a combination of forward-thinking people in academic institutions combined with the appropriate people in the ministries.
Okay, thank you for that, Andrew. Harriet, from your interdisciplinary kind of viewpoint.
So I suppose we're very lucky we have a really strong relationship with the Africa Health Research Institute in South Africa, and have come across no problems working with them. But I suppose we don't work with countries per se, but in terms of individual sharing of health data over mobile phones, I think there's a real lack of understanding of what people are sharing every day over their mobile phones, and I think there needs to be a lot of increased awareness, because people say, oh, I don't want to share this aspect of my health data, but they're sharing a lot more kind of intimate things every day. So there's a real kind of challenge there.
Yeah, I mean, you mentioned ethical considerations in your, I was very interested to hear about that, simply because when you're mapping that out across a region, how those different ethical interplays are going to affect that. But that's, thank you for that answer. I sort of push out to the audience.
Does it work?
Yeah.
So I'm Blaine, I'm the CEO of diagnostics. We are a point of care manufacturer focusing on the care. So I was very interested about the data session. Everybody kind of talk about that. And when we speak with governments, especially in Asia, we of course sense in the first contact there was a great willingness to, yeah, it would be great, we want more data and so on. And sometimes if a program fails, a lot of data will show the government that actually the program failed. So we heard that in a couple of countries where some officers were not so keen necessarily in implementing surveillance data for dengue specifically because they were afraid that that data would come out. So have you ever, can you comment on it? Have you ever encountered any comment like that?
Yeah, I have. In lots of countries, that's one of the frustrating things we come across. As I say, we're a technology provider, so we're there to do the job for the client, and our clients are often large implementing NGOs or their big private sector companies or their ministries. And I've seen a lot of individual people reluctant to share data because it's going to reflect badly on them. We've got an issue in one particular country we're working in, where in one region the managers or the regional directors and the district health managers have almost vetoed the use of the system because they're in such a mess. They don't want that mess to become visible. So and it's kind of a backward-looking thought process because rather than saying, okay, well, we know we're in a mess, having visibility of the mess will enable us to take some positive action and sort it out. They just kind of put the shutters down. So it's the reality sometimes of life on the ground, and it's very very frustrating. And you need it all boils down to people. You need strong people to get in there and make things happen. And we're lucky that we work with some really good clients who've got those people, but we still come across pockets of resistance. People have got their own motives for stopping data becoming public.
Would you like to add anything to that, any of the panelists?
I'm kind of thinking about it. I guess the fairest way to say this, I have experienced a little bit of it with a particular group of people who were collaborating with a large multinational, and they actually did promote the product for as long as they were collaborating, and as the collaboration and I suppose the funding dried up, I suppose their mood very much changed against that multinational's product. So I think there is an element of I suppose bias when multinationals are involved, and I suppose political influence. That's as much as I'm going to say.
Okay. There's a question from Jim Mullery.
Mine's not a question so much as a testimonial. I just wanted to say that my R&D team in California with Millipore Signal, they love the Mango software. And we've had a lot of experience with it developing diagnostic assays, and it's been successful. It's very successful so far.
Great to hear.
Thank you, Jim, for that. Brilliant. Looking forward to your speech a bit later as well, Jim, as well. Yeah.
David Robinson, Natural History Museum, interested in neglected tropical diseases. First of all, congratulations to all three speakers, some really interesting ideas and data. I think my question is particularly for Andrew, because I am interested in mass drug administration, the implementation of control programs in some of these very difficult settings. And I found your presentation very stimulating and really would like to follow up on it. But I'm just wondering, because many people are very overwhelmed by data management at that kind of local level. What kind of capacity building is needed? What kind of training is needed to get people really involved with the implementation?
It's a good question. It really depends what their involvement is. The guys on the ground who are conducting the census and sending in the distribution data, the training's very limited. We always try and keep things as simple as possible. That's number one. The simpler you can make it, the more likely people are to engage. So when we started with Site Savers in Cameroon, the only sort of communication channel that was available to us was SMS. So we just broke the indicators that they needed to send in down into some simple codes you know, A means this, B means that, C means that, and then you follow each code by the number that you've got on your piece of paper that you've been writing down as you go around. And they tend to pick that up within a couple of hours. I mean, funny enough, the biggest hurdle we had to overcome during the training process was teaching people to text, because in a lot of these countries, well, in some parts of, like in Cameroon, that country, that people hadn't been using their mobile phones to text, they'd just been using them to make phone calls. So we had to, you know, let's say we put aside a morning for training, 2 hours of that morning was taken just getting people comfortable with texting and finding the characters on their keyboard, because some of these little phones are tiny, and if you're asking them to use letters, they've got to, you know, you've got to input that letter several times to get to the letter that you need. So, so it's you know, kind of almost unforeseen things like that you have to kind of work around. But in terms of the data transmission, it's very simple, and as we've you know, over the years that we've been doing this, more and you know, better, easier to use network services become available. So in Nigeria with Sightsavers, they're still using basic mobile handsets to transmit the data from the field, but we've been able to use a different channel. It's called USSD, and it basically means that we can open up a session. So it's you again, just with a basic handset, you just dial. When you're ready to submit your data, you just dial a session number, so it's like 150*# something like that, and then the Mango system then pushes down in real time a set of questions in the real language, saying how many people have you seen today, you know, how many, you know, so basically you're asking them proper questions, and then they just put in a number in response to the question, and the question's in their local language, and then that, you know, that data collection process might take 30 seconds or a minute, and then they just end the session, or when they put in the last answer, the session ends. So it's really simple, and again, that reduces the training kind of burden at that end. It's at the, as you kind of move up the sort of data chain, if you like, and you're getting into the program management team who may not have had access to you know, more of a sophisticated reporting system before. That's where you need to spend a bit more time, and that can be a day or two of sitting down with them so they can see you know, what the data is, how to interpret it, what actions to take if they see something that's wrong. But again, you know, it's a couple of days exercise at the start of the program. I mean, we're lucky insofar as we've got a guy on our team who used to work for Sightsavers. He was the program manager for the MDAs for Sightsavers. After the initial exercise, he joined us, so he's now our training guy for all of the MDA activities. So he's, you know, he's been at the front end, and now he's at the, you know, he's poacher turned gamekeeper, if you like, or the other way around. But yeah, it's not that complicated. It just it's matching the training to, you know, the role within the process, and keeping it as simple as possible.
Could I morph that question, David, onto to Harriet from an upstream perspective? And we've heard very much about a deployment level, you know, resource capacity issue. But from an upstream, you're working with very complex technologies, CMOS, the embedded systems, the quantum dots, the nano materials. You're active with the Africa Centre. Is there a research capacity issue, any of this, for you?
That's a good question. I think we're very lucky that the Africa Centre is quite well provided for. It's actually now the combination of two separate institutes, and it's actually funded by Wellcome and a host of other centres. But absolutely, I mean, the area itself is incredibly in need of capacity building, and obviously, you know, the wider area moreover. But I think in terms of accessing kind of end users, and because we would prefer for people to be self-testing, so we're actually trialling an HIV self-testing app that links to clinical care pathways in South Africa sometime in the next few months. And obviously a massive component of that will be how complex can the app be in order for anyone to pick it up and use it without any training at all. And that is a massive challenge, because, you know, there are things that you just don't think of, like, for example, not having experienced texting before. And then there's, you know, if you're taking a photo of a test, then there's a whole host of issues around that and image capture that we really have to account for. Okay. So it's a challenge.
It's a challenge. That's interesting. Any other questions from the audience, please?
No, again, fascinating talk. Really enjoyed them. Linking a little bit, actually 2 points. Linking a little bit with the comments and the questions that we had yesterday, where we tried to find commonalities between different presentations and the different partnerships. I'm wondering, how can we combine all the 3 different presentations we had today in a single stream of, management tool that actually, collects the data from the diagnostic point of view, collects the data, the monitoring and evaluation indicators, sends all this information to the managers, decision managers of the different ministries, at different administrative levels, and return all this information, feedback information to the people, because it's something that we normally forget, the feedback loop. We don't tell the guys on the ground how they're performing, how their work is performing. So I'm just wondering, how we can integrate these 3 pieces together, rather than having just a piecewise approach to all these things. That would be an ideal situation. And the other comment I'd like to, or the other question I had is, love the way you, Andrew, presented the benefits and added values of these tools. Wondering if you quantify these things, because at the end of the day, the decision maker at the ministry will have to decide whether the system brings more value for money than alternatives. And I'm just wondering if you quantify this thing. I recognize that you mentioned about $70,000 savings from one of the projects. What about the other things, the other benefits that you mentioned?
Sure. Okay, 2 great questions. Thanks very much. I'm sorry, I'll take this if you like. In terms of the first question about integration, absolutely. There's mileage to be had in integrating these solutions. I mean, we've already done some work. I think I mentioned with Amiga, a company called Amiga Diagnostics, and they've created an rapid diagnostic test kit for CD4. Which unfortunately I think has been superseded now, but the object of the exercise is their point of care tool. We created an application that could read that point of care tool, enable the clinician or the health worker to put in some additional data about the patient based on the result that they'd seen, to refer the patient on for either further testing or put them onto a treatment program and update the client record, and then push that kind of record through a workflow. So that was a one integration that we've done. We do a lot of work of we'd like to talk to these guys about their point of care tools and incorporate that into it's an obvious thing to do to bring these tools together. I was at the London School recently talking to, there's an organisation there called Peak Vision, and they've created some really nice eye care tools on Android applications, and they're all these tools are built to be part of an ecosystem. So those kind of almost like triage tools. The findings from the triage exercise need to be reported and acted upon, and people need to be, who are found positive for a certain condition need to be referred on and tracked. So all those things are now coming together. Connectivity is kind of the buzzword, if you like, and we're very much kind of behind that. I've never really looked at the numbers, but probably half of our clients have now started to integrate Mango with one thing or another, either at the front end with these diagnostic type tools or at the back end with other systems, logistics management systems, so we can share data about the commodity tracking, or things like DHIs, 2 district health information systems, so we can push client data into a more comprehensive client file that covers programs other than the ones that we're working with. So connectivity is a big deal. In terms of the cost-benefit analysis that you're kind of referring to in your second question, that's something that is kind of a pet subject of mine, is how do we present our, how do we kind of encourage people that it's a good idea to take on these technologies. I mean, Sightsavers were pretty good because they shared their findings with us. They showed their increased coverage, their reduction in time in the field, and the cost savings. And it's kind of a client-by-client thing to provide accurate, meaningful, kind of reliable case studies like that with some bottom line. We need a lot of input from the client, because they need to share with us what their findings are. How much was it costing you before? How much is it costing you now? How much time was it taking? How much is it taking you now? And they're all well-meaning. They all want to help, but they're all busy doing other things. So we've actually found it quite hard to get accurate feedback from clients to help with those. But so we often use anecdotal evidence to support it, and often as not, when we're talking to potential clients, they know what their problems are, and the benefits that we're talking about kind of ring a lot of bells, and they can do the calculations themselves. And again, in many cases, we are responding to requests for proposals. So again, someone's already done the homework. They know they need some help, and they anticipate significant benefits. But yeah, if we could create a library of case studies that are properly costed, that would be fantastic for the clients and for us as well. A useful sales tool.
Would anyone to add to that?
I think just to add to it slightly, just a sentence is much like you said. I think to integrate the 3 projects and the 3 companies like ours together, you won't do it just ourselves. It has to be with the stakeholders on the ground, and I think that's the most important thing, is to take in, I suppose, the knowledge that is there. Because, I mean, take for example ourselves, we recently started working with, 7 months ago, with an epidemiologist based completely in Brazil. I mean, we learned things from, a chat over coffee with her that we probably haven't, it would have took us 3 months to learn. So I think there's a lot of knowledge on the ground that shouldn't be taken for granted.
And I mean, I suppose I'd like to ask Harriet the same question, but in a different guise, in the sense that what we're talking about here is actually partnerships, isn't it? And this was touched upon yesterday. You've got very complex mixture of different disciplines that form iSense. What makes it work?
Good question. I suppose you really need to bear in mind that it is quite, it's upstream, and we're just hoping that as long as we, optimize each different facet, so the nanomaterials, the lateral flow assays, the app interfaces, the ethical frameworks, and then at some point they will all come together. It's definitely a challenge. I just wanted to answer, I think someone asked about how does it feed into online platforms. So it's not through a diagnostic test, but in South Africa, we have an online dashboard for, Rosanna mentioned the 90-90-90 targets earlier for HIV, and it's a large kind of study area in KwaZulu-Natal where every single individual is kind of surveyed every year, and according to whether they are, what their HIV status is, if they are HIV positive, whether they're on treatment or not, and if they're on treatment, whether they're virally suppressed. And all of that information is on an online dashboard, and it feeds into the Ministry of Health. So that's an example, although it's not from directly from diagnostics, it's kind of an example of it, being available for anyone to look at. And
Good. Thank you for that answer, Harriet. I mean, I'd like to spin. I'm just going to come to the last question, I guess. There'll be time for someone to ask questions from the audience, but I just wanted to spin this backwards a bit from the panel to the audience, in the sense that we're speaking about collected data, right? But what about data that's already in existence in terms of the NGOs and the various longitudinal data, the case studies you've got, the case managements you've got? I know we've got the leprosy mission, England, Ireland, Wales here, as well as MSF. So I'd like to ask the leprosy mission in terms of your viewpoint on the potential role of the NGO in this kind of data puzzle.
Yes, I'm Sheila from the Leprosy Mission England. Yes, you're correct, we do collect data and we do collect a lot of case studies, but at the moment a lot of our case studies are going in to be shared with the United Nations for their SDG collection, to show where we are impacting our work to meet the SDG criteria. Within ourselves though, we are looking at how we manage and collect data for diagnostics. Obviously for the diagnostics for leprosy, it's a difficult thing to kind of culture, but it is an area that we are looking into. And it is an area that we're kind of thinking which way is best to go around it. Obviously making sure the data we do offer is shared across the whole of the kind of leprosy fellowship, if you will. So even though leprosy mission sits underneath a leprosy fellowship, which is all around the world globally, through the University of Netherlands at the moment, whatever small data we have, we collect and we share. But kind of sitting here, I'm quite conscious that it needs to be shared wider sometimes, because it's not just leprosy data we'll collect data on trachoma, and we'll end up collecting data on LF as well, which stays in our little hub and not really shared out unless we need to go back to it at some stage.
when we're entering territory into co-infections, comorbidities, so absolutely, and that's something that Lawrence touched upon as well. Lawrence, if you don't mind, from MSF's perspective, data that's already collected, how does that fit into everything that we're talking about? And I'm sorry to detract from the panel, but I think it's an interesting mirror.
Yeah, I will not hide that data collection is a big disaster in MSF. It's very complex because the end user, I don't know if they are fearing or whatever, but we are working now with the DHS2 platform that give a bit more of real time, meaning when I'm in Barcelona, I can see on specific mission and follow some pattern, but the main problem it's how the end user is entering the data.
Yeah.
So that's also maybe one of our lessons learned. It's when you build this kind of platform, it's often a top-down, what we call a top-down decision, meaning it's people from the headquarters in MSF with a group of specialists around that define what will be the optimal database and what need to be collected. And at the end, it's often totally disconnected from the reality. And people don't understand why they have to fill so many documents and why they have to send so many documents. So that's one of the things. I think it is important on the development of these kind of things to already involve the people that are going to use it, and for them to feel part of the whole process and then to get better outcome. And then on the other side, how we use it. We use it for let's say our internal reports, but also external, some advocacy plan. What we face is sometimes with sensitive data, especially related to outbreak, we cannot share more because the government, the typical example, it's today there are ongoing outbreak of cholera in Ethiopia. We cannot, even if the government have the data and provide the data, they will totally refuse to admit that cholera is existing. So there are also whatever you generate in sometimes in some platform, it's even impossible to share this. So it's make the things much more complex. And the last things that for us is very important, it's now we are speaking of data collection, but I think this kind of tools and platforms could be also useful on feedback. You know, to when I was saying it's, if the diagnostic is centralized in a reference laboratory, the most complex is how do you bring back the result to the patient. So it should be for data collection, but it should be widely used for others. Alert system, we use similar platform for vector control in Chagas in Bolivia, where when somebody saw the triatomine in home, they can activate by a simple SMS and say, I think somebody needs, and then you activate the process. So there are many use, apart from the pure data collection, which at the end, I don't know how many people really interpret it well looking when you see the thousands of data they are collecting.
Thank you very much for that, Lawrence and Shabina, in terms of the reportage line potential. Would there be any other questions? Please feel free. Rosanna, brilliant.
I'd like to share with everyone our experience of piloting this data management for the Minister of Health and the Chief of Life Services to have real-time data on what's happening with HIV, CD4, and anemia testing. Is that before we started to even plan the pilot, we have to have workshop on data governance. What's the data? Is there privacy, confidentiality involved? What can be public and what could be kept confidential? And also, the governance of that data seems to be particular to each country because they want to have
then secondly, even after we got permission to have the pilot, we found that the fields that we like to collect from, in each one of the company clouds, the fields are called something different. There's not, any convergence in the ways that the nomenclature of each field, the data field is. And so we needed companies to actually harmonize or standardize the data fields, etc. So there are many, many issues, and this is, again, where partnership, leadership is really important, so that we don't all of a sudden start to have many different data management systems that don't talk to each other.
Yeah.
And for us, our pilot was based on an open source middleware solution that could draw that data from each one of the company clouds. But we had to work with the companies to do that, and it would be nice if there is some open system that everybody start to subscribe to and start to make things a lot easier.
Perhaps that might be the next revolution. We've had it in drug discovery, so starting clinical trials, so let's hopefully it'll carry on. Thank you very, very much for that. Thank you very, very much to the panelists for some brilliant speeches, as well as taking time to sit here.